The most important question that we have to be able to answer is, when should we do a rebiopsy on this patient? PSA kinetics is a really helpful tool that we use all the time to determine whether to do a rebiopsy on a patient that previously had a benign biopsy. For example, by looking at PSA velocity, which measures the rate of rise in PSA over a period of time, physicians can get a pretty good sense of what's happening. For example, recent studies have shown that an increase of greater than 0.75 nanograms per mil in a patient with PSA levels within the gray zone was indicative of cancer. In a separate study, it showed that a decrease in free PSA levels within the serum associated with an increased risk of prostate cancer. The details are not important at this stage, but what we should know is the purpose of these tests. So in summary, PSA kinetics allows the physician to assess when to do the repeat biopsy on a patient that previously had a benign biopsy. It also does another thing, that is, it allows the patient to assess when to begin treatment for insignificant tumors. Because the fact is, most prostate cancers don't actually kill. Prostate cancers are generally slow-growing cancers, and if you remember from my previous video, I told you that most diagnosis was made over the age 70, which means that the likelihood of the cancer killing the patient, as opposed to other comorbidities, is greatly decreased. And because of that, we don't want to be wasting both time, money, and also decreasing the patient's quality of life by overtreating patients with clinically insignificant tumors. So we do this by differentiating what is important and what is not. So insignificant tumor would include any of these criteria. Any one of these three will be considered an insignificant tumor. Now, I'm not going to explain a whole lot. You can just pause the video and read the slide yourselves. One thing I will say is, with this last criteria here, this last bit of less than 10-year life expectancy was not mentioned in lectures. But the fact is, it is in the criteria, and typically we're talking about patients who are very elderly and patients who are very sick. Okay, so in other words, patients who are very elderly and patients who are very sick with a Gleason grade of 6 or less have what we consider insignificant tumors, and therefore will not be treated. Now, the majority of these men with insignificant tumors will undergo after surveillance, which is essentially obtaining clinical history, doing a digital rectal examination, and doing a PSA test every few months just to survey. We'll keep an eye out on the cancer. The threshold for treatment traditionally used to be when signs of advanced cancer began to arise. So signs such as back and bone pain would be an indicator that you should begin treatment. Nowadays, there's a lot more asymptomatic patients being treated due to the advent of tools such as the PSA kinetics, as well as research showing the benefits of earlier treatment. So now I'm going to spend the last couple minutes talking about two specific lesions that you must know. The first one is high-grade prostatic intraepithelial neoplasia, which in layman terms basically describes a normal-looking gland architecturally that is lined by atypical cells that look a lot like cancer cells. So these cells would have enlarged nucleus and perhaps a prominent nucleoli. The basal cells will be present, but occasionally they may be fragmented. High-grade PINs are considered precursors to prostate cancer, but despite that, their significance is unclear because recent studies have shown that patients with high-grade PIN are only at a slightly increased risk of developing prostate cancer compared to the rest of the population. Also, low-grade PINs are no longer reported because it's very subjective and has no prognostic value. Now finally, we're going to talk about atypical small actinide proliferation. Now keep in mind that this is not a specific pathologic entity, but rather describes a continuum ranging from benign atypical looking cells to cells and glands that are borderline cancer. patients who have been diagnosed with ASAP are recommended to have a repeat biopsy right away because of a very high risk of cancer on repeat biopsy. Up to 40% of those who have been diagnosed with ASAP will, on subsequent biopsy, be diagnosed with cancer. So that basically concludes our section on prostate cancer. I hope it's been helpful. If you have any other questions, just leave it in the comment section below, and we'll get back to you as soon as we can. Thank you.